to introduce our speaker, who's our summer intern. Isaac's background is that he grew up in California, in Davis, California. And then he went to Lewis and Clark to study math. And his background was mostly pure math. And as he went through college, got interested in how he can apply that theory to real-world practice. And then from that, got interested in healthcare, and then got interested in biomedical informatics. And so he spent the summer working with a group of us, basically Michelle and Sarah and Isaac. And they've been doing sort of a clinical workflow modeling simulation, and then the piece that Isaac's going to talk about, which is visualizations of EHR timestamps. Okay, so Isaac, why don't you go ahead and get started here?
It's lovely. So thank you all for coming. I'm Isaac, and I'm going to talk about what I was doing this summer, which was mostly creating visualizations of EHR timestamps. So I'm going to start off with a little bit of some background and motivation for why we're looking at workflow problems of EHR records in the first place, and then I'll talk about the visualizations themselves, and then some data problems that they illuminated for us, and then a little bit on what's next. So why don't we get started? So I'm just going to talk a little bit about the context of the problems that we were facing. So in 2008, electronic health records were used by just 17% of physicians and 12% of hospitals in the United States. But there was a lot of basically information that said that if you start using electronic health records and you can manage to coordinate care for patients, you can both improve their health outcomes and also reduce the costs, which is a very attractive proposition. And so in 2009, as part of the economic stimulus package, the HITECH Act was passed by the federal government to help incentivize hospitals to invest in these fairly expensive and complicated systems, which has been a very successful endeavor. By 2014, 76% of hospitals were using a basic electronic health record system. So that's great. Unfortunately, with a big change like that, there are some challenges, and there are very particular ones to productivity. So just looking at OHSU and KCI Institute in the Ophthalmology department, after adopting the EPIC healthcare system in 2006, ophthalmologists see on average 2 to 5% fewer patients than they did before, and it takes them about 40% or more additional time per patient encounter, which is quite a lot. At the same time, there's a strong pressure for providers to see more patients in fewer time for less reimbursement, and there isn't really a lot of guidance on how to do that effectively with these new challenges that people are facing. So the focus of our research group is to try and alleviate some of these productivity problems, although actually not through solving the electronic health record problem, but rather by trying to address issues related to scheduling and resource management within the clinic themselves. So trying to address structural problems there. So the idea is to try and come up with strategies to better manage the resources in the clinic or to better schedule appointments so that work flows better. But that's not really the sort of thing that you can test out on actual clinics. So you have to find some other way to test out your ideas. And basically one way to do that is with discrete event simulations. So you can create models of your clinics and try and test new ideas, switch models, and see what you get by doing that. But for a model like that, you need a whole lot of data in order for it to run effectively. So where does the data come from? Well, electronic health records keep track of every person who's logging in and out of them all the time. So the idea is that what you can try to do is take the times that the provider has been logged in and logged out of the system as a proxy for the time that they are spending with the patient themselves, and hopefully that will work out. So when we're talking about modeling, and we're going to talk about modeling in ophthalmology clinic today, the reasons for that is that it's a relatively complex clinic. In an ophthalmology clinic, you see some kind of you have some kind of initial exam with some sort of an ancillary staff member, a tech or an orthoptist. You may have your eyes dilated, so you would actually leave the exam room for a certain amount of time and then come back before seeing the physician. So there's a lot of movement back and forth between patients and staff. And so it's a reasonably interesting problem, and it's still reasonably generalizable. If you go to a regular physician, instead you would see a nurse and have your weight taken and your temperature taken and all that sort of stuff. So it's still applicable to other places, but still an interesting problem to look at. So the hope is that these electronic health record timestamps that we have will sort of line up with this idea of the model, and we'll be able to use them as a proxy and use it as data to do things with. So other members of our group, Sarah and Michelle, not me, did a bunch of work validating the electronic health record timestamps. So they went and observed actual clinics and took measurements. So what you have here are the two distributions for exam time duration for staff and for physicians. The blue is observed, the pink is electronic health records. And when we're running a model, what the model is going to do is it's going to sample from this distribution and take exam times from there. So what you want is for these distributions, the blue and the pink, to overlap as much as possible. And the good news is they overlap quite a bit. So that says to us that we have models, we have data that's good enough to use for them, and so the next question is, what do you want to test? And that was sort of where I was brought in. So I was brought in to create timelines of these ophthalmology clinics using Tableau for about a year's worth for about 4 different clinicians, and try to generate strategies for reducing wait time. And there are a lot of different things that you can do with something like this, but we decided to try and focus on reducing the amount of time that a patient is waiting. And try to answer, of course, the question of what does a bad or good day in the clinic look like. So that's what we did. And this is an example of one of those timelines that we came up with. So basically, each bar represents a patient appointment. And then you have a couple of different things to go through. So the yellow-green stands for the time that a patient is waiting, but they are early. They are before their scheduled visit time. The electric blue is time when the patient is not there yet, but they were supposed to have been there, so the time they're late. Gray stands for time that they're waiting. They're not seeing anybody, and it's in their scheduled appointment time. And then the other colors stand for their interactions with various staff members. And then red for when they're dilating. When their eyes are dilated, excuse me. And that's pretty cool that this sort of works, and you end up with a reasonably nice picture of what a day looks like, and you can kind of track the provider moving throughout the day pretty convincingly, which is quite exciting. And just to sort of go through further, you can click on all of the different little colorful bars, and it'll give you some information about who was logged in, how long that particular bar was in duration. It can do a couple of other things, but that's what we have it doing right now. Oh, and by the way, I forgot to mention these numbers here. This is the scheduled visit date. That's what that is. So just to sort of zoom in on this one in particular, sort of some promising things that we're initially looking at. This day had this really long provider exam time in the morning. That could be sort of delaying exams later on in the day. There's also this sort of triple of dilations that's happening here. That's also possibly preventing the provider from seeing a different patient earlier. And so there's the sorts of things that add up and cascade throughout the day, perhaps. And then we also sort of started to examine good days versus bad days. So this is a much better day than this one. There's a lot less gray going on. And so you can see some real differences between the two, and that's reasonably promising. But basically, the more that we looked at these charts, the more that we started to see that there were actually problems with the data itself. And so we started investigating that. So that's what I'm going to talk about next, is problems with the data that we're trying to solve or have solved that we found because of these visualizations that we made. So problem one has to do with overlapping timestamps. So again, we're trying to solve reducing patient wait time during a day. So one of the things that we need to know in order to know how long a patient is waiting is how long they are busy, how long they are with somebody doing something. But what can happen, of course, is that there are multiple things that are happening at the same time, which show up on our timelines as these sort of overlaps, so that we have sort of a tech, and the tech starts a dilation time for the patient, but the tech is still working, the tech is not yet logged out, and then we have this provider coming in, again, while the dilation is still happening. And so the problem being that when you have these overlapping times, you have multiple things going on at the same time. If you try and count all of these separate bars as time that the patient is busy, you're overcounting. And so pretty frequently what happens is, if we're taking the wait time to be the difference between the total appointment time and the times, and all of these times that they're with somebody, we end up with negative patient wait times, which is clearly not happening. So we had to kind of work through how to straighten out this problem. And basically we came up with an algorithm that does that. So this is sort of an example for our algorithm in basically the scenario that we had before, slightly exaggerated, where we have a technician who's talking to the patient, and then they start a dilation process, but they're still talking with the patient and doing something. And then the patient is dilated, and then perhaps the provider shows up early, and we have all of this overlap that's going on here, and we don't really want that. So what our algorithm does is it takes for a particular appointment, it takes all of the interactions that are happening during the appointment, it puts them in order, and it starts comparing them. So we take green first, and we compare green to red, and we slice off all of red that overlaps with green, and we get this nice chunk here, which is great. And then we move down, and we take yellow now to green, and we slice off all of the yellow bits that overlap with green. And then finally, we now move on to red, and we take all of the yellow that overlaps with the red, and we slice it off. And now we end up with this total bar here, which is the actual time that the patient is busy seeing somebody, which is the actual number that we're interested in. So that was quite nice. So that was the first problem that we actually managed to solve. Do you have a question?
Sorry, I might have missed this.
Yes.
That dilation time is put in. That's an EHR timestamp that someone puts in. That's when they did it, or it's when they? Okay.
Good question.
Like,
yes.
So it might have been a little earlier or a little later, but
yeah, we take like an average
okay.
time of like how long it should take. Yeah. Mm-hmm.
Why is it necessary to slice out like the dilation in the middle of, if your goal is to get the actual time the patient is busy, why not take the earliest start time and the latest end time and just be done with any in-between details?
I mean,
I'm just curious, is there a reason to
well, so essentially what we're trying to do is figure out what's overlapping, and then if they're overlapping, then we get rid of the part that is overlapping. But it's possible that there are events that happen in between or later on that don't overlap. So in the process, so we just have to make sure that we're finding all possible overlaps, and then if they overlap, we're getting rid of them. So we can't necessarily, so when we do find that they overlap, yes, we are taking essentially the start and the end time, but not all things overlap.
Gotcha.
And then, are these times when people are being charted, is that based on when they log into the workstation in the room, or is it based on?
Yeah, it's when they log into the workstation in the room.
So then a tech and a provider are both logged into the workstation in the room at the same time?
I mean, this is a slightly exaggerated example, to be honest with you, but I'm not actually sure. Can that actually happen?
I'm just asking.
I have definitely gone through and I have seen things in the visualizations that look like a provider exam, and in the middle of the exam, the tech shows up and does something else. I don't know the details of how that works, and perhaps that's an error of the visualization, but it is certainly something that shows up, and so it's something we have to deal with. I don't know.
It's not usual, and then this is sort of an example, just kind of showing it's not real. But in general, yes, it probably be more likely that the tech overlaps with dilation, and then the provider overlaps with dilation, but they're not.
Yeah.
Yeah, I also think that some of these workstations may have been mapped to generic workstations that aren't necessarily in the room, but maybe in the hallway, so you could have two people log in at the same time. Or someone may not log off. Because they may finish their room, like that. That's
still working for that patient.
Yeah.
Cool. Great. So that's overlapping time problem, and then we basically found another problem that looking at data more. So the other problem is that basically we were missing data. So there are a lot of different timelines where you have these really enormous gaps between patient interactions with some staff, and basically there were so many that we just started to get suspicious that we were probably missing something. Just to sort of zoom in, here's a particularly good example where you have the tech meets with the patient who is like an hour early, and then nothing happens for 40 minutes, and then they see a tech again, and then nothing happens for another hour, and then they see the provider, and we just sort of saw this over and over again and thought that's fairly unlikely, and so we're probably missing something, which it turns out that we were. So basically what we were doing, from here what we did is we went back and looked through the data, again, using a different search. Originally our search is based around finding all of the appointments for each provider associated with each provider, but, oh man, I was going to have this highlighted, I guess I forgot. But when we run this search again, not doing that anymore, we pick up this provider exam, which we had before, and then we actually pick up 2 other exams that happen. And pretty nicely, these slot into exactly where we had those gaps before. So it turns out we were missing these other exams that happen where a patient is sent to go and get a visual field test, or they're sent to have their eyes photographed or something like that, which is not associated with the provider, but it happens still within the exam itself, so we have to keep track of it. So we sort of went back and found, oh, there's all this other data that we're missing, so let's try and pull this data. And we did, but that ended up giving us a few other problems. But I guess basically first, before I talk about that, we found out basically that our original model was not really correct, that there's this other thing going on with imaging and visual field that we have to take into account, and so we need to adjust our model. So we're doing that, and then we try and pull some new data, see what it looks like, and it doesn't look so nice. So the most immediate problem when we pull this new data, this is the exact same appointment as it was before, but things have changed a little bit. Somehow the checkout time is now 10 p.m. The reason for that is that one of the appointments that we searched up had a check-in time, but now no checkout time whatsoever. And so we have to put in some kind of dummy time while we're trying to figure out what to do with that, basically. And one of the things that we're currently working on is trying to come up with rules that help us end these appointments without checkout times, which is a very common problem, actually, with these other appointments that we're picking up. But I mean, there is some good news if you sort of look at all of the different colors and roles that we're now starting to pick up. We're picking up a phototech, we're picking up a couple of other things, so we are picking up new information. But the other problem is that you'll notice a lot of these bars are really thin, and in a lot of cases, all of the new information that we're picking up is for times that last for like less than a minute, which still suggests that we are not really pulling up all of the data that we're looking for. And so that's an ongoing problem that we're trying to solve now. Yes?
So I don't understand how you had an end time before, but then it disappeared.
Right. Okay, so what we had before is an end time for this appointment in the middle, which has a checkout time. But we don't have a checkout time for this appointment right here.
Oh.
And so, and this happens this is just this particular example, but this happens all the time with a variety of appointments where we don't have a checkout time. And so we still have to put something in here before it will sort of show up nicely in the visualization. And we just pick something really, really, really long for now, and then we'll fix it later, basically.
So you're just showing the latest end time of anything.
Yeah, I mean, that's definitely one thing we're doing. Yes, actually, I think you need to hear it first.
That's
Cool.
going to be my suggestion.
When pulling this data the first time through, is there a reason why it was done by provider and not by patient? Because if it was done by patient, then this would have come up early. I was just curious because I know from previous work it was something about like seeing if certain providers were slower or like if certain providers had different times of, and that's why it made sense for that. But then for this, like, it's just because he was continuing that process, and that's why. Okay.
Cool. Great. So that's most of what I have to say today. Big takeaways. Visualizations can help generate strategies and possible hypotheses for increasing clinical productivity. They can also be really good at finding new problems with your data that you otherwise would not have seen. And there are still many problems with using EHR data to get a full picture of a patient visit. So our ongoing work, we're trying to create rules to define when an encounter is ended in a way that will sort of be most useful to us, and search for this missing data. Future work, incorporating this new data once we find it, and generating test strategies for improving workflow. So that's pretty much my presentation. I want to acknowledge and thank all of these people and organizations, and that's what I got for you. Any questions?
So when you're like slicing out things that overlap, say later you want to go and look at the average dilation time. Are those values the sliced off values, or do you?
I'm keeping them separate. So when we're slicing it off, I just create a new variable that's just like, I think I call it like actual exam time or something like that, and I just sum up all of the sliced pieces and totally leave alone all of the original data. Because you're right, we totally want to look into all of those things as well. Yeah.
How often does the last time, the end time of the last activity correspond to when the patient actually checks out?
Basically, it does for a particular provider because that provider's practice is to hit the print button when she's done with the patient, and then we can just use the print time as the checkout time, and that works like very, very well, and it looks pretty nice. But in a lot of cases, there's at least some leftover time after the last provider encounter, but usually it's not like egregiously long. Occasionally it is. If somebody forgets to check out, or all sorts of problems totally happen. But for the provider appointments, generally there is some like reasonable checkout time that's available. Yeah. Yes.
When were your, I might have missed this because I came late. When were your data collected? How long ago?
Well, this is electronic health data from 2014 right now. Yeah. That's what that is. Yes?
So, I mean, this might be a non-issue, but, typically with dilation, there's a certain amount of time you expect the patient to wait, like, or is there a certain amount of time that you expect? Is that something that you can separate from expected wait time to unexpected wait time? You have a certain amount of time that you expect the patient's just going to wait for it, or they have to wait for something, but versus to really narrow, I mean, even that wait time itself is just one gray bar, but in the same way that you've been able to expand and get further detail on these simple encounters or just more detail, that wait time itself is just one gray bar. Is there any more information you can gather from that wait time itself? I mean, if you're trying to reduce it, is there more?
Do you mean like, are we basically taking into account the time the patient is waiting while they're being dilated? Is that what you're
while they're being dilated, is it just wait time for dilation, and that we expect that, or is that? I mean, I don't know.
Yeah, we just call this red bar. This is the average time that a patient is waiting while
that's
their
the
eyes is
expected
dilated.
time for the dilation. So okay.
Right, so
Yeah.
in the electronic health record, the staff are very vigilant about reporting the time when the patient's eyes were dilated because they really need that information. They need to know exactly when they're dilated.
So I put the dilator in, and then they're ready to
So
go.
they put that time in there. So we're not using the timestamp of when they entered the dilation time. We're
It's the whole dilation.
putting the time that they said that they were dilated. Now we don't always know exactly when that dilation is done, and there is variability between patients. We use kind of an average, so we expect them to take about 25 minutes for their eyes to dilate. So that's why sometimes we have overlap, because we know that their eyes are dilating because we know that timestamp that we put that in there, and we know that it takes about 25 minutes, but there might be other things going on. So we don't want to count, even though dilation is, patient is kind of waiting for dilation, it's still productive waiting, and we don't want to count that against us.
Right, that's what I'm saying. So
right.
That,
So that's why it's red as opposed to
I get it. Okay.
Yeah.
And it's the same reason why we want to highlight when a patient is like early before their scheduled visit date. We want to differentiate between time that they're waiting before they were really even supposed to be there versus time that they're waiting when they're actually scheduled to be there. Yeah. Yes?
Did you do any kind of observational analysis to see if, kind of related to some of these gaps, if there is activity being done related to the patient that isn't captured in the EHR, maybe a couple providers doing a consultation in the hall or something? Because what you're getting at is really not patient waiting time from the patient's perspective, it's are we working on this patient while they're here?
Yeah.
And if so, what'd you find?
I have not been too involved with that sort of thing. One of these wonderful people may be able to answer better.
Well, Sarah and I have been doing lots and lots of observations.
Yeah.
And so we have seen some of the things that popped up as being missing data. And actually doing this work and doing more searches, and this is all pretty recent, so and he's reporting on this because it's his internship, so we're still investigating some of these things. So we are going back and do more observations to see exactly what's going on, what's being recorded in the EHR, what we can get from the EHR, and then what's actually being done in the clinic, and we can actually kind of time that and see what the differences are, because we really do think that, like for example, the visual field might have, just it looks like there's a minute in the EHR, but we know the visual field takes longer than that. So but at least we know if we can get that from the EHR, we know that happened, then maybe we can do enough observations to say on average we know that, okay, that took 15 minutes or 20 minutes or whatever.
Rob, I think that was a really good point. And just to follow up on what Michelle was saying, that obviously the type of interaction that you're describing probably cannot be captured in the entire timestamps. And so, I mean, of course we know that because these guys had observed in the clinic manually to figure out what's really happening in the clinic, so then we can benchmark the EHR to what's happening. And so I'm not sure that there's a real way to represent that using a big data kind of paradigm. But it's an interesting point.
Is there only one provider, one tech, and one resident, and one
No. There's usually, for these charts, there's only one provider, but there's often many different techs. And in one of the first slides I showed you that you can click on all of these bars and see who's logged in for that. And when you do that, you do get that representation of which tech was where, but it's kind of hard to represent on just the
We get a feature chart with another sidebar to show which resources are being used at home, like just averaged across all of the different patients.
Mm-hmm. Yeah, definitely.
Is it normal to have the residents and fellows not seeing the same patient? In other words, it seems to me that I don't see residents and fellows on the same patient. And I may be misremembering, but I might be in your data set for all I know. I happened to see Dr. Lombardi and got my eyes dilated sometime in the
Nice.
distant past. But I could have sworn there was there was her and then a junior learner in the room. And I was wondering if you capture that granularity, or would it just show as her?
I think that harks back to the question about there's only one exam room, one computer in an exam room, it's only one person is signed in. So, for example, if Dr. Lombardi had a resident and a fellow, Dr. Lombardi would swipe in and only her data would capture, and maybe a resident would come in later and document stuff that they'd seen, but when there's numerous providers in one room, it's whoever's logged in, it's their EHR data is going to be represented.
Gotcha.
I guess my last question is, now that you have this data kind of in, the next question is now the context for that wait time. What do you believe is causing that wait time, and what kind of what's next step? Like what strategies have you thought about for reducing that? Would be the last question.
Yeah. So, I mean, we're basically thinking about different stuff, and we're actually going to go have a meeting with a provider tomorrow to get her input on what, when she looks at these, what does she think is what's going on? But basically from what I personally have observed, I think there's a very noticeable effect when the provider has a really long exam time in the morning, and that's also borne out by a bunch of work that was done before I got here as well. So that seems to be a big thing, that where you schedule the exams that you know are going to take a long time matters quite a bit. I think there's also probably something to be said for where you schedule dilations that happen at the same. It's weird. Dilations, I think, do something, but sometimes they sort of staircase really nicely and everything goes fine. But sometimes if you have two dilations that are basically happening at the same time, that can be a real problem. So I think there's definitely subtleties in how to arrange that.
Right.
And also probably some issues with when you should be double booking people and when you shouldn't. So I think those are the main three that have really become clear.
And the other thing too is, try and look at actionable things, right? It's and if you look at this visualization, you can see almost, looks like all of the patients were early. And if not, I mean, some very significantly early, right? So we all know that late patients can disrupt things, but early patients can a little too. So one of the questions we're trying to figure out is, when do you work in that early patient? If someone shows up 2 or 3 hours early, when is it okay to put them in and not cause other people to wait because you saw something wrong? Does that make sense?
Yeah, I mean, this is, you know, even beyond the scope of this lecture, but, you know, something that every clinic deals with is reducing wait time. I mean, this is not a unique thing. And, you know, there are things on here that, you know, it's difficult to capture. For example, and this is ophthalmology, but take, for example, primary care. You know, when I worked in a clinic, you know, wait time can sometimes be just affected by the complexity of the patient. If I have someone just coming in for a med refill, that takes 10 minutes.
Right.
But then I have someone who is, I know to be complicated, has multiple medical issues. I can't predict, no matter how good I am, they might just take up a lot more of my time. That pulls everybody back. Now everybody's being delayed.
Yeah.
How do you reduce that? How do you, you know, so those types of trends I think are even more interesting, because then I can optimize in that direction. So that simple patients, you get them in and out, you have a very efficient part of your time. And then other patients, you block out more time for them. And these kind of little things, you know, this is really great data, and I think it's a really, you know, really interesting. I think you did a great job. What I'm really interested in is that next step is now creating context for the numbers that we have.
Yes.
Because then from there, you can actually kind of take steps forward to really action, as you said, actionable items.
Absolutely.
You know, I think those are great points. It's, you know, Michelle's done some really neat stuff in terms of looking at sort of short, medium versus long patients, and how can we predict who's going to be a short versus a long patient and stuff like that.
And you know, in my previous hospital, you know, my program director mentioned, he said that one department, they kind of did it based on weather. They said this is a, you know, sunshine patient, this is a thunderstorm, like kind of predicting what they say. You know this patient is just going to take up a lot of your time, save it for the end of the day, or, you know, save them for whatever time and just be ready for that. And that, I think this data gives us that. If you can see that the provider is spending so much time with this patient on a consistent basis, and that's why I think, as you said, if it's patient-centered, now you have that, you know, now you know what each patient is, because I think maybe that would, you know, give you more context for that.
Isaac, thank you very much. Great
Thank
job. Isaac is really, great job. Yeah, Isaac has really done a nice job, you know, this summer with stuff. He's been a lot of fun to work with. You know, when we were scheduling this, you know, Andrea and Lynn basically said, well, is it okay to split the time and have a faculty talk in the second half? And so I said, well, sure. And then so she came back and said, well, what's your title? And I didn't realize it was going to be one of us. But what I did is, so, you know, we actually thought about having Michelle and/or me talk about some simulation stuff, you know, as a prelude to what Isaac was doing. You know, that gets into a lot of these other topics. But you know, decided that had been pretty well covered by stuff that Michelle has presented, you know, in this forum recently. And so I thought what I would do instead is talk about some stuff involving an eye disease that I work in called Retinopathy of Prematurity. And you know, it's some stuff that there are several of my students who've been involved with this. You know, and you know, 2 of them who you guys would know are Ryan Swan and Aaron Coiner, who's an incoming student in September. And so, you know, rather than, you know, really focus on the eye disease, I'm hoping to zone in on a few take-home points, which is these concepts of science, informatics, and art of medicine, and how all this stuff comes together. So I'm hoping that's going to be the generalizable point that you know, that people take away from this. You know, the thing that I want to highlight, there's some financial disclosures that aren't really, you know, relevant to the stuff I'll be presenting. But the thing that I want to highlight with this is, number one, that a lot of people, you know, worked on the data that I'll be showing. In fact, you know, most of these people are not me, and you know, I'm actually in charge of a consortium that includes, you know, these people. But the other thing is that these people come from all sorts of different disciplines. There's informatics, ophthalmology, computer science and engineering, public health, and genetics. You'll recognize some DMICE people, Kamal and Ryan and Aaron, you know, up there. And so what I sort of take away from this is that, you know, science and informatics and research are really more and more interdisciplinary, you know, than ever before. Okay, so I think that's one really neat take-home point to this. And so this eye disease is called Retinopathy of Prematurity, ROP. Okay, and Stevie Wonder was someone who went blind, the singer, because of ROP. And it's one of the leading causes of childhood blindness in the U.S. and also throughout the world. And it's treatable if you diagnose it early. Okay, you treat it with laser or some injections into the eye. And what really happens is that you get a retina, the back part of the eye that's developing. Okay, so a baby gets conceived. Okay, the blood vessels in the retina start growing and growing and growing. And by full term, the retina should be fully vascularized, okay, the blood vessels. But when you get these babies who are born prematurely, okay, they're born at 24 weeks instead of 40 weeks, the vessels haven't fully developed yet. And you get these babies who get exposed to the outside world. About 2/3 of them get a disease, this disease ROP. And what that means is that instead of normally vascularizing, the retina starts to grow irregularly. Okay, and that's what ROP is. Okay, about 2/3 of premature babies will get this. And it usually goes away by itself. In about 10% of the time, it doesn't go away by itself. And then you get these Stevie Wonder blindness cases unless they're treated. Okay, so what we try to do is identify which are the ones that get this, which are the ones that are likely to go bad, and then treat those babies. Okay, and so I really want to focus on these concepts of, we'll call them science, informatics, and art. And I'm just going to give two examples of work that we've done, I guess, in my career. And I'll start with the traditional teaching. Okay, talk about research, that we and others have done that kind of question that traditional teaching, and then talk about some lessons and what the clinical impact of that is. And hopefully that's going to be the generalizable, science, informatics, and art type of lessons. Okay, so here's example one. Okay, so we talked about two examples. Eye exams, ophthalmoscopy. Okay, when I started practice in 2001, there was a practice guideline for ROP that was published by the American Academy of Pediatrics and the American Academy of Ophthalmology. And it said that these eye exams should be done using indirect ophthalmoscopy in the neonatal intensive care unit. Okay, so that's a headlamp, a lens, and you're examining a baby. Okay, and that's the standard of care for these eyes. And all these babies are hospitalized, and you basically look at the retina and draw a picture of what you saw. Okay, hand-drawn sketches. Okay, and that's pretty much even now the state of the art. So what are the challenges of this? From a practical perspective, it's really time-intensive. Okay, you have to travel to the NICU, coordinate with their staff about which babies to examine. It'll take half a day to do a typical set of exams. The exams themselves are really difficult. They're very imprecise and subjective, and I'll talk more about that. Okay, there's more and more babies who are surviving who are small, and fewer and fewer ophthalmologists willing to do this. Because it takes so long, because it's hard, because you don't get paid a whole lot of money, and because there's enormous medical legal liability, actually biggest in all of ophthalmology. And so, really, especially in rural and other medically underserved areas, this is a huge, huge problem. Limited access to care and also training for this disease. So the second aspect in terms of challenges I want to get into is training. Okay, a few years ago, I got interested in this issue of how well are we diagnosing, and particularly usually it's retina specialists and pediatric ophthalmologists who do these eye exams, and at the last stage of medical training is what's called a fellowship, when you subspecialize, and so how well do these fellows perform for doing eye exams, and why do we care how fellows perform? Okay, number one, because that's how we build a workforce for disease. And number two, because studies have shown that about half of ophthalmologists who do this disease are actually not even retina specialists or pediatric ophthalmologists, they're actually general ophthalmologists. And so in other words, they have less training than these fellows do. And so I never believed that until I moved to Oregon. And there are a lot of general ophthalmologists who are doing ROP care in Oregon because of that rural bit. Okay, so this is sort of the real world. And so we recruited basically 12 fellows. These are from good fellowship programs around the country, and saw, well, how well do they perform compared to a gold standard of an experienced ophthalmologist panel. And this is their sensitivities for diagnosing basic clinically significant levels of disease. These babies are at risk for blindness who get this level of disease. And how they're doing is sensitivities of 51%, 54%, 36%, 32%. And so basically these fellows are missing, in a lot of cases, up to 2/3 of clinically significant disease. So basically, this is a big problem. I mean, we're not really doing a good job of treating this, or teaching this, let alone treating it. Okay. So, one thing that we got interested in years ago was, can we use telemedicine, for this purpose? If we've got such big problems in delivery of care, can we train nurses to take pictures of the retina using these commercially available camera systems, and then build essentially repositories, have them upload the data to those repositories and make a remote diagnosis and send recommendations that way. And so how would this help? Well, maybe better quality, better cost, better accessibility of care, and also better objectivity. So, for example, this is the hand-drawn sketch. This is the photo, and these are actually the same retina on the same day. And I think that you can argue that you get a lot more richness of data that's being captured by the photo compared to this sketch. Okay. So one of the first things I did in my career was I worked on a K-23 project. A K grant is an NIH sort of career development award. And those of you who are fellows now, may be interested in doing this. And Michelle right now is funded on a K. And so if you have questions about that, talk to her. The title of my K grant was called Telemedicine for ROP Diagnosis. And we basically built systems, evaluated their accuracy, looked at the reliability of the technology, cost effectiveness, speed, and so on. It took 6-7 years to do the work. And I think the first part of this is, can you get the correct diagnosis using a photo compared to doing a real eye exam? And so, we published papers in this, other groups published papers, and I worked on a technology review, of this. And, basically it turns out that the data are pretty good. Okay, there's very high sensitivity for diagnosing clinically significant disease. And all of these studies are based on the design where you get the gold standard is a real eye exam. And the experiment is you take a picture of the eye and you interpret it, and what's the sensitivity compared to that gold standard. So the short answer is that sensitivity is very high. But one of the questions we got interested in is, how do we know that the eye exam is the gold standard? In fact, is it really inherently better than taking a photo of the retina? And so we got interested in this. This is actually not an easy question to answer, but it's really, really important in medicine, especially as we're developing all these new technologies. And the gold standard can be listen to the heart using a stethoscope or something. And the device can be machine that images the heart. And so the way that we tried to study this is looking at this question of how well does telemedicine agree with the real eye exam, ophthalmoscopy? In other words, comparing the two. And this is actually a hard question to answer because there's often significant variation among different doctors. Okay, I'll talk about this afterwards, but even when you show two people the same data, they often come up with different diagnoses and impressions. And those of you who come from medical backgrounds know this. So we came up with this study design looking at intra-physician agreement between telemedicine and ophthalmoscopy with the premise that if it's the same observer, you can neutralize for this factor and then just analyze the diagnostic differences that are due solely to the modality, telemedicine or ophthalmoscopy. So we basically collected a large data set, had these people do the real eye exams, and then had them go back and do telemedicine exams 6 months later on the babies that they had examined originally and compare their diagnosis. Okay. And when you do that, there's 86% intra-physician agreement between telemedicine and ophthalmoscopy. Okay, so that's pretty good, but it's not perfect. And then when you go back and look at those discrepancies, so 86% agreement means 14% discrepancies. It turns out in about a third of those discrepancies, the gold standard exam showed no disease, but when you look at the photo, there's actually a disease that was missed, that white line. Okay. And there are a lot of issues in clinical diagnosis that are very subjective. Okay, where's the disease? Okay, is it really close to this optic nerve, or is it far away? And the point of this is that with telemedicine, in principle, you can make those diagnoses for these discrepancies more clearly because you can map it out and draw it out and figure it out on the image. Whereas when you're trying to do this with a baby who's wiggling at the bedside in the neonatal ICU, it's often really hard to be precise. And so we felt like in principle, you actually might get a more accurate diagnosis if you've got the photo compared to a real exam. So I thought that was interesting. And we did some studies involving cost effectiveness and speed. Yeah, I'm looking at this because it's saying that the computer's going to restart in like 12 minutes. Because of see what happens. So in short, we did some decision analysis, modeling, and some time motion studies to show that, yes, in fact, the telemedicine exam is more cost effective and it's faster compared to the ophthalmoscopic exam. So I think what I took away from this is some lessons. And number one, within the past 5-10 years, there have been major real-world programs in the U.S. and around the world that use telemedicine for actual diagnosis. And I think that's really neat because it comes from the research that's done. And the other thing is that the revised American Academy of Ophthalmology and Pediatrics guidelines in 2013 came up with this quote. And I was actually on the panel that came up with this quote, which was carefully wordsmithed and meant to be very vague. But this is what it says. Digital remote interpretation is a developing approach to ROP screening. At minimum, if you do this, you should comply with the recommendations outlined here, which basically says you can do it, but be really careful. Okay, I think. And but to me, I thought that was really, really neat because it sort of showed that you do that, you've got that need, you do that research, and then you get it into policy. Okay, so it's that multi-step thing, and so you get to sort of close that loop, and it actually happens. There's a technical report that was put out, looking at, well, how do you really do this from a workflow and implementation perspective? And so I think the lessons that I take away from this are, number one, how important it is to have that multidisciplinary approach. And again, that issue from going to research, to that need, to the research, to the adoption and policy of new technologies. Okay, so that's example number one. Example number two is what I'll call gold standards and classification. Okay, so it turns out that when you diagnose this disease, back in the old days, the diagnosis of ROP was completely descriptive and unstructured. Okay, and what that means is that you would basically use an ophthalmoscope, look at the retina, and just draw that picture, okay, with no infrastructure for what the findings really mean. And in the 1980s, there was a classification system that was developed, international standard for clinical exams. Okay, and what they did is they basically defined parameters, and the parameters happen to be called zone, stage, clock hours, and plus disease. Okay, and so all of a sudden you've got this standard terminology, okay, for ROP, and I would make them, and this was the mid-1980s, and in ophthalmology, in a lot of medicine, I would argue that there is not a lot of standardization, and not nearly as much as we probably need, okay, of this sort of thing. And you guys know this from an informatics perspective. And so I think that this was a really big deal. And there have been these large-scale sort of multi-center randomized controlled trials looking at, well, how do you treat disease, who needs treatment, how do you treat it? And so you can't have these trials without this infrastructure and this terminology. Okay, so I think that's really important. It turns out that according to these trials, the most important parameter of ROP is what's called plus disease. Okay, and plus disease is sort of a Boolean variable. You either have it or you don't. Okay, yes or no. And there's also pre-plus. That's an intermediate state. So basically, yes, no, or borderline. Okay, pre-plus. And so if you have plus disease, the baby needs treatment, basically. Okay. And what does plus disease mean? Tortuosity of the arteries, okay, and dilation of the veins in the back part of the retina. Okay, and how do you know how tortuous is tortuous, how dilated is dilated? There's a standard published photograph here that was selected by experts back in the 1980s. Okay. So if you have this much or more abnormality, you have plus disease, you need treatment. Okay. So it turns out that what's the challenge of that dogma? When I was starting out in practice, I saw this baby referred, and the chief complaint was, I think this baby has plus disease, you need to laser the baby. And I looked, and I thought, well, it's really not that dilated and tortuous. Okay. A few months later, this baby comes in, and the chief complaint is, this made me a little bit nervous. Well, how can I be that far off? From an expert who's been doing it for 25 years, out in Brooklyn, I was practicing in New York City at the time. A few months later, this baby comes in, okay, very tortuous, very dilated. The chief complaint is the opposite. I've been following this baby for weeks, and I'm wondering if you think this baby needs treatment. And I looked, I think it should have been treated a long time ago. Okay. And so I thought, well, we can't, this and this can't be at opposite ends, at the same time. And so we designed up some really, really simple studies, which is basically, putting images on the web, inviting experts from around the world to go log in and enter their diagnosis, plus, pre-plus, or normal. And this one, a little bit of tortuosity, a little bit of dilation, 15% plus, 85% not plus. This one's split 50-50. And there are examples like this all over that we have where the experts themselves don't really agree. And so this is where I want to get into this science and art of medicine. So what's plus disease? I once gave a talk at a conference, and there was a course panel, and one of the other instructors says, well, plus disease is like pornography. Potter Stewart, a U.S. Supreme Court justice in the 1960s, defined pornography, and he says, well, I can't define it, but I know it when I see it. And so this buddy of mine says, well, plus disease is like that. You know it because it looks bad. Okay, I'm not sure if that's good enough. We want to do science and informatics. It's not good enough to say you know it when you see it. And what we thought, well, can we capture and encode detailed qualitative thoughts of experts using almost like a think aloud protocol? Okay, so we basically did this. We captured who we thought were the 7 most senior experts in the world on this, and had them go through a bunch of cases, and we videotaped them, and had a cognitive informatician who I used to work with. We built some mental models of this. And just some examples, these are the exact same case. One person diagnosed at plus, one diagnosed pre-plus, one diagnosed normal. And they're all looking at different parts of the retina, and they're all making different qualitative comments with that. So they're not even necessarily looking at the same thing. When you look at the different features, this is the definition, arterial tortuosity, venous dilation, but they're all commenting on different parts of the retina, in addition to what the definition is. Okay, so I think in some ways we're not really good at articulating what we're doing. And so this gets into the point where, if we want to make the argument that diagnosis is very subjective and qualitative, can we quantify it, using computer-based image analysis? And I worked with a team of people. A lot of you know, or some of you know, Jayshree Kapathy-Kramer. Okay, she used to be at DMICE, and she works in Boston now. And Dennis Dogma used to work here at OHSU and moved to Northeastern University in Boston, 7, 8 years ago. And Ezra was a PhD student at Northeastern who we worked with together. And we looked at some questions like, can we develop computer-based systems to quantify these diagnoses? What does that require? In other words, what are these gaps in knowledge? Well, you got to segment the vessels from the images. Identify what's vessel versus background. Identify which image features are the key ones to quantify, and how do you quantify them? You've got to have a reference standard to compare against. If everyone says something different, how do you know what the correct answer is? And you've got to define standard image size, standard image shape, for analysis. All these different steps. And just a couple examples of this. To come up with a reference standard, the way that we did this, a medical student, Mike Ryan, gave an AMIA talk on this a couple years ago, is that we had 3 different people review the images for each eye, and you characterize it. Is it plus, is it pre-plus, or is it normal? And then we had a majority image-based diagnosis, and then you compare that with the actual clinical diagnosis by ophthalmoscopy. If they're the same, then that's the gold standard diagnosis. If they're different, then we have a conference to sort of resolve the differences. And so we looked at all these different image features. Okay, which retinal image features correlate best with the actual clinical gold standard diagnosis? And it turns out that of all these are all previously published kinds of algorithms. The best one was something called acceleration of the vessel on the average, which basically means how quickly the vessel is changing direction. So almost like the second derivative of the position, the xy coordinate. And when you do that, the performance of these systems, so we've got 8 different experts, and you've got accuracy compared to that reference standard diagnosis, that consensus vote. And the experts are between 79 and 99%. And we can train up this computer system it's 95% accurate compared to that reference standard. Okay. And if you take the consensus of these experts, it's actually 97%. Okay. So overall, what I take from this is that, number one, experts are highly variable. And these are actually world experts. They've all published and are considered sort of legitimate world authorities in the disease. And the computer system is doing pretty well. And I don't think this is ready for prime time for reasons that we can talk about, but it's actually not bad. And I just want to show basically one or two more curves, and then we'll finish up. I thought this was a neat curve because we've got two data sets. Okay, 100 images, and this one happens to be 34 images, 8 experts. Okay, and red means that expert diagnosed that image, 1 to 100 as plus. Yellow means pre-plus, green means normal. Okay, so you see here, this expert diagnoses plus disease 6 times more than this expert. Okay, and this is a big deal to miscall that one way or the other. And the other thing is that if you average the score for each of these and convert it to a color, the abnormality goes along a spectrum. Okay, so in a way, when we sort of classify it plus, pre-plus, normal, you're taking that continuous spectrum of abnormality and you're slicing it into 3 different discrete categories. And the point of this is that experts differ based on where they draw the line. Okay, we've actually gotten pretty good data showing that different experts order images the exact same, but they slice differently. Like this person slices it here, this person slices it here for plus versus pre-plus. And that's exactly how these computer systems can help. They can sort of help us draw the line a little bit better. So my computer may restart over here. I don't think there's a way to prevent this. But I want to just come up with a few lessons, if we can. Okay, one of them is this issue of computer and information technology. I think that, to me, this has done a lot to change the way that we practice medicine. One piece of advice for trainees, don't be afraid to ask dumb questions. Okay, I thought that this question about, do people agree with plus disease, for me at the beginning of my career, I was really insecure about, do I really know what I'm doing compared to these people? And it turns out that nobody really knows what they're doing. And so, we actually got multiple grants and sort of build your career on something that seems like kind of a dumb question. And so I think the way that I would close this up would just be, we tried to show some examples of the science of ROP, which is like classification, treating disease. And to me, the art is, sort of this stuff like, what's pornography, what's plus disease, and there are subtleties that really can't be captured by that classification system. And I think that's real. And to me, the informatics means things like telemedicine, computer-based image analysis. And I guess the point that I want to sort of leave with is that good clinical care requires that combination of all of them. And I think that as informaticians, to me, it's sort of that's what our piece is, sort of figuring out how to mix that informatics with that science and with that art. Okay, so thank you very much.
So first question I had was, so you mentioned that telemedicine was cheaper, more cost-effective. What was the reason for the increased cost for manual ophthalmoscopy? I mean, I'm just curious. What was the reason for the increased cost? Because on surface, it sounds like it would be cheaper to just go there and look with a ophthalmoscope. So what exactly? Where were the costs? How was the cost there?
Yeah, the way that we that's a good question. The way that we modeled this was based on sort of the cost of telemedicine being, how much do you charge for a telemedicine exam? And it turns out they're actually significantly cheaper to do than ophthalmoscopic exams. And I think that's the single biggest cost savings. When we did this modeling, we didn't model it to include things like, how much does it cost to buy your machine, whatever. And so that's a little bit more complicated. But the numbers were that it was about 40% more cost effective, based on strictly sort of a Medicare reimbursement model.
Okay. And then my other question is, in terms of, and I know this is difficult because again, you mentioned just now, like kind of creating a gold standard, but with the diagnosis, then the next step is, does the fact of using telemedicine, does that lead to better outcomes, like preventing blindness? So that, I guess, would be my second question is, has that been shown to have as good or, as good if not better outcomes as
Yeah.
Right.
That's a great question. It's really tough to answer. I think that I don't foresee that there's ever going to be a trial that looks at outcomes, because it would just take so long to end up doing with the incidences of these, diseases. And, what we do know is that outcomes from, and, quite honestly, with ophthalmoscopy, we never know really why babies are going blind when they're going blind. Is it because they were meant to go blind, or was it because they weren't getting screening or they got lost to follow-up, or is it because the person who did the eye exam miscalled it and then, let something go, like in those examples up there. And so, I think that those are really, really tough in the real world to get to the bottom of. What we do know is in the operational telemedicine systems out there, they've actually had very good outcomes. And so I think it's a really tough question to answer. But my guess is that that's going to be the best that anybody can ever do with it. Sure. Yeah. Okay. So first here, then.
You mentioned that even though you're getting, I believe you said 96% hit rate with your system, which is roughly 1% less than the census of world.
Yeah,
experts.
sure. It was 95% accuracy versus 97%.
And you said you don't think it's ready for prime time. In certain other areas, that would be considered really nice.
Yeah.
What are some of the reasons that you think it's still not ready for prime
Yeah.
time?
Let me tell you why. One of them, the biggest one, is that the system that we use here required manual segmentation of the images. In other words, the computer system wasn't that, it picked up a lot of garbage when it was doing automated segmentation. And it happens that if we do a purely automated segmentation system, the performance is actually pretty good also, but it's just not 95%. The other question, so I think that's reason number one. Of course, we can come up with a system where you help it by refining it, which we don't have yet. The second thing is that I'm not sure that we've fully characterized exactly what are the best parameters to look at. Now, maybe if we can get 95%, and there are world experts who are getting 79%, maybe it doesn't really matter in that case. But I do think we want to do a little bit of extra work on that part.
Maybe only use it to screen for the green cases. Essentially, something that an expert doesn't need to look at because it's so likely to be not disease plus.
Yeah, it's funny that we've been trying to do that exact project right now. Look at how would we draw that? How good is that? Using a bigger data set compared. This was 100 images. Using a bigger data set, and so I think that's exactly along the lines of what we're trying to do right now.
And then toss all the edge cases
exactly.
and the obvious ones to an expert.
Yeah, exactly. Yeah. Okay. Yeah.
So what I was wondering is both about the current practice with ophthalmologists, and are they in routine practice at this point of taking images when they do exams, and if not, why not? And then the second thing being sort of like, do you have a lot of issues with inter-photographer variation? Like the quality of an image is probably going to have a big effect on your ability to interpret it remotely or have a computer algorithm interpret it. So is that a difficult situation?
Yeah, those are great questions. In terms of the first one, which is, do we take photos routinely? We do at OHSU. But one of the reasons we take them routinely is that we do a lot of teaching and we do a lot of research, and so we take photos for that reason. In the real world, I think that most NICUs have a camera, and most people are not routinely taking photos along with the eye exam. And it's probably because of time constraints. It just takes twice as long to do the photo and also to take a photo, to do the exam and also take a picture of it. In the real world, Isaac was talking about these eye exams, and when you go to the office, a lot of times people do get photos taken. And I think probably the reason for that is that it's not the doctor that's taking the photo, and it doesn't interfere with the doctor's workflow. It makes the patient wait longer. But you just get to the doctor 30 minutes after you otherwise would have. so I think that's sort of the first answer, the photo part. The second part is the quality of the image. I definitely think that it matters who takes it. And I don't think we have great standards for training. And in a lot of ways, I think that you could argue that does it matter who your surgeon is, or which radiology tech took your photo? I think that all of us who do medicine know that it does matter, but it's not always that easy to get to, how do you know whether it's good or bad? How do you, standardize that stuff? And so one of the, actually it's interesting, Aaron Pointer, who's the incoming, DMICE, one of the incoming PhD students, has been working on a rotation with us over the summer where he's looking at some algorithms for assessing image quality, where the idea is that it would do something similar. These would filter out, this image is good enough or not good enough for processing. And, we'll see where that goes, because I think that's going to get a little bit to what you're asking about. Great. Well, guys, thank you very much.
Thank you.